The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. My name is Emily Smith. I work at St. Anthony Hospital in the Communications and Marketing Department, and I also help with the community outreach. First of all, I just want to say thank you so much for taking time out of your morning to join us to learn about our community health needs assessment. We started this work last year with PRC to gain information about our community, and we are excited to share the results with you. So with that, I am going to pass it off to Bruce Lockwood with PRC to give our presentation.
Good morning, everyone. Thank you, Emily. Happy to be here. Glad to have you here today to share with you really the first audience to hear the results of this assessment that was recently completed for Umatilla and Southern Morrow counties. As Emily mentioned, this is our second assessment. The first one was in 2021-22, and now we are completing the second of these in 24-25. So before I dive into sharing some of the key findings from this assessment, I wanted to start out with a little bit about how we did this assessment. So we looked at pulling in data from multiple sources. So of course we consulted existing data that's out there, what we call secondary data. Those are county level data. Here we referenced Umatilla County, pulled information from places like the census, the CDC, other public health, and other health related data sets. We also did two surveys as part of this process. One was an online survey that was administered to community stakeholders. So health providers, physicians, other health providers, public health, but also social service representatives and various types of community leaders. And I'm guessing that many of you today listening to this presentation probably took part in that online key informant survey. Now, much of that was very qualitative in nature, and all of those input are included in our final report that will be made public. But today I'll just have one slide around what we learned from that key informant group. Probably the cornerstone of this assessment, though, was a customized local health survey that was administered throughout the population. And it was a survey of residents themselves, asking them about their own health status, their behaviors, their experiences. And it was a combination of phone and online surveys to do this. And I want to talk a little bit more about how we did this so you know where that information is coming from. So in all, we collected just over 200 surveys among adults living in the targeted service area, which you can see on the map here. It includes all of Umatilla County and zip 97836 in Southern Morrow County. So throughout that, we administered 201 surveys, which is a decent sample size, giving us a respectable error rate of plus or minus 6.9% at the 95% confidence level. It was a rather long survey, over 100 questions, and took some time to complete, but we had good participation. We were able to capture a lot of information from residents that I'll highlight today. Now, once the information was collected, we took all of that survey sample and weighted it into the actual proportion of the population so that it was representative of the community. And in fact, I'm going to throw up this chart here at the bottom that shows a percentage of different demographic characteristics based on census data in the orange columns compared to the final survey sample proportions in the red columns. And I don't want to get into this too much, but essentially the takeaway is for each of these key demographics, the representation in our survey very much looks like the population. And that's what allows us to say this represents the population, and we can project those findings more broadly. So today I want to accomplish a couple different things. So during this webinar, all of the attendees are going to be in listen-only mode. So we can't hear you when you speak or your background. But we do want you to be able to ask us questions. So to do that, I want you to feel free to use the questions dialog box on the GoToWebinar dashboard to submit questions at any time. If you don't see questions, you can also use the chat box. Type in your questions. I'll save some time at the end of the presentation and go back and field those questions, but feel free to type those in at any time. We're also going to present a lot of data to you, but we want to get your feedback on that as well. So we're going to use some interactive platforms to get some feedback from you using a mobile device or a web browser. So we're going to ask you to log in, answer some questions that'll appear on screen, and submit your responses. And we're going to do this a couple different times. I'm actually going to do this on the next slide, just to test to make sure everything is working as expected. And then at the end of the presentation, we're going to ask you to give us some feedback on the data that you heard. So go ahead, grab your cell phone, your tablet, or open a separate browser window. And I want to get some of your input. I want to test this system, make sure it works for you. So once you have that mobile device or that web browser, you can either use the QR code here, or you can enter menti.com and use the code that appears on the screen. And that should bring you to a new screen. Go ahead and do that now. Right. So I want you to ask the question that now appears on screen. So it should appear on your mobile device or on your web browser. We're going to ask you that if this community were a breed of dog, what breed would it be? And I've given you 8 options here. So when you are made your choice, go ahead and enter it and be sure to hit the submit button that's at the bottom of the screen. That's what will transmit your scores to us. Looks like we have responses coming in, so things appear to be working fine. Uh-oh, we've got Lovable Mutt edging out the Jack Russell. All right, looks like just about everybody's. A couple outliers, but some consensus, I think, around this question. Of course, this is just, a silly icebreaker that we're using to test the system. But later on, I'm going to have you essentially use the same platform to give us some feedback on the data that you heard. So we're going to present some data around needs that have been identified, and then ask you to start to rank order those essentially and give us some input as to how those should be prioritized in the community. And I'll talk a little bit more about that later as we get in. So I want to share one slide that we represent some of what we learned from the Key Informant Survey. So the Key Informant Survey, remember, was a separate survey that was done with providers and community leaders. And we essentially asked them initially to evaluate, I think, 16 health issues and tell us whether they thought each was a major problem, moderate problem, minor problem, or no problem at all for this community, for Umatilla and southern Morrow counties. And in doing that for those issues they were most concerned about, we had a lot of follow-up questions asking them to explain why and such. But what I want to share today is kind of their rank ordering of these health issues. So for that key informant group, those providers that responded to that survey, clearly mental health was their top concern. Almost 3 out of 4 rated it as a major problem for this service area that we're looking at. From there, you can see there's a pretty big drop off on their major concerns. Certainly, social determinants of health, which is a big umbrella, was a significant concern at 31%, rating it as a major problem, followed by substance use, cancer, tobacco, nutrition, physical activity, diabetes, and then a number of health issues that ranked lower there. But the takeaway here is really they're very significantly concerned about mental health above and beyond the others. And I share this because I want you to keep this in mind as we go through some of the data that we collected, and you can see how much this comports with what we see in the other data, and be open to looking and see if there are other issues that emerge that may not have been top of mind when this was done. So for the rest of the presentation, I'm going to focus on the data that we collected from the external sites, but also that survey of residents themselves. And I'm going to go through and show a couple slides for each of these issues that I've shown on the screen. I'm going to start out with some general measures of health, but move pretty quickly into what we call these areas of opportunity. So these are issues where we saw that the service area was either compared unfavorably to some of the benchmark data or where we're seeing some adverse trends in indicators. And I'll have a couple of slides around each of these. As you can see here, I'm going to go through these alphabetically because, again, at the end of today, I want to get your feedback as to how these should be ordered. So I know I said I'll address questions at the end, but I did have one come in that asked about the service area definition, and that is really kind of based on where the hospital's patients originate from. So we focus on looking at those areas where X% of patients, for example, originate. So that is how those zip codes were ultimately included for this assessment. So the first thing I wanted to share was this question that I have on screen, and it was actually the very first question of the survey of residents. And we asked people, in general, would you say that your overall health is excellent, very good, good, fair, or poor? And you could see the distribution here. Half rated it excellent or very good, another almost 30% rating it as good. So all favorable ratings of health up to that point. But what we really tend to look at is those lower two categories, fair or poor. And here you can see 20.9% of residents rated their overall health as fair or poor. And this is one of the few questions in the survey that is really perception-based, but I'll tell you that it's one that's pretty telling and really correlates pretty strongly to a lot of the other measures that we have in our survey. So if we take that fair-poor response, we can look at it in a couple different ways. So we can compare it to the same question that is asked in a statewide survey done by the CDC or by a national survey that's done by my firm, PRC. Same question. This is how we compare to those responses. You can see a couple percentage points higher in the local service area, but really the differences there are not statistically significant. So we're fairly close to state and national prevalence for this fair-poor response. To the right, you can see what that response was in 2021. And again, you can see the current response is a couple percentage points higher, but that change is not yet statistically significant. It needs to be a little wider to be statistically significant. We can also look at the current fair-poor response for the service area by demographic characteristics. So if we look at the Umatilla and Southern Morrow County population that we surveyed and break it out by gender and age and income level, you can see that the responses do differ. And I've highlighted some here because those are statistically higher than what we saw in the rest of the samples. So significantly more women than men rated their overall health as fair or poor. It was significantly higher in this middle age group, age 40 to 64, even compared to those older, 65 plus. Also higher in the low income versus the mid to high income category. And for my charts today here, this low income category includes households that earn up to 200% of the federal poverty level. So that's almost 60,000 for a family of four. So it's a group that encompasses a lot of families in our service area. So moving on to these areas of opportunity. Again, these are where we saw some needs emerge from the assessment for one reason or another. And alphabetically, I want to start out with access to care. And certainly a very important part of having access to healthcare is whether someone has health insurance coverage. And what we found in our survey is that insured levels are very close to what we see statewide and nationally. So for this slide, and this slide only, I'm excluding the Medicare population because we know they have that coverage. So for adults 18 to 64, 7.2% were without any type of health insurance coverage, whether private or public sources like Medicaid. 7% with no coverage whatsoever. Also statistically similar to what we recorded in 2021. But beyond health insurance, and we know that there are other factors that can impact a person's ability to access healthcare. So we actually had 7 other questions that asked about specific barriers. So for example, at the left here, our survey found that 29.3% of all adults in the total service area said there was a time in the past year when they needed to see a doctor, but they did not because they couldn't get an appointment when they needed it. 18.2% didn't go to the doctor at some point in the past year because they couldn't get there during office hours. 15.7% had trouble finding a doctor. 12% didn't go because of the associated cost. 10% said they needed a prescription at some point in the past year, but they didn't get it because of the cost of that prescription. Roughly 10% also said transportation was an issue for them. And then less than 1% cited difficulties with language or cultural barriers. Now, we also asked the same questions in a national survey. So for Americans overall, we actually see that many of these are much higher. And in fact, those that I've highlighted here are statistically worse nationally than they are locally. But even so, if we take all of these barriers for the local service area and roll those up into one number, it's almost half, 47.9% of our residents who've encountered one or more of these barriers in the past year. Another slide that I wanted to share related to access is the availability of primary care. Now, this is a chart that shows the number of practicing physicians expressed as a rate relative to the population size per 100,000 population. And by this measure, here, Umatilla County, which I'm using as more representative of our service area as a whole, is significantly below what we see for the state and the U.S., with 50 primary care physicians. Now, one caveat to this chart is that it does not take into account advanced practice providers who may be also delivering primary care at various settings. But still, we did see in our survey of residents a drop in the percentage of adults who say that they have a specific source of ongoing care, meaning that they have a particular doctor or clinic that they go to for their routine health needs. We saw a drop of about 10 percentage points since 2021 in folks having that kind of relationship. Next topic area I wanted to talk about is cancer. Cancer is the second leading cause of death, second only to heart disease. Accounts for 17.6% of deaths in the service area. When we looked at mortality rates, so age-adjusted rates of death, based on age and size of the population, there we compare pretty close to what we see across the state and the nation for cancer overall. But looking at specific cancer sites, we do see a relatively high mortality rate, specifically for colorectal cancer. In our survey of the population of residents, we asked them about age and gender appropriate cancer screenings. And for those that we tested, we compared generally pretty close to or better than what we see at the national level. In particular, I point to female breast cancer screening, which includes mammography for women aged 50 to 74. And you can see locally over 80% of women in that age group report mammography in the past 2 years, much higher than what we see at the national level. Cancer screenings for cervical cancer and for colorectal cancer, which affects both genders, very close to what we see nationally, right around 70% in those groups getting appropriate cancer screenings. Diabetes is next on our list. When we look at some of the public health data, so this is data based on death certificate information, we find that mortality for diabetes has historically been high in the area, above what we see statewide and nationally, as you can see here. It increased for much of the 20 teens, but has since come down a little bit. So not a real clear trend in the data, but what is most concerning is that it is relatively high compared to those benchmark data and has been for a number of years. In our survey of residents of the population, we asked people about past diagnoses of diabetes. So from that, we found in this red column, for example, 13.4% of adults in the total service area currently have diabetes, which is close to what we see nationally, close to what we saw in 2021. But to the left, you can see that it is significantly higher in the 40-plus population. And that's consistent with what we see in most every community that we work in, that diabetes is a very age-related condition, and age is the strongest predictor of diabetes. Now, in addition to this 13.4% have been told they have diabetes, our survey also found another 10% who say they've been told by a medical professional that they have prediabetes or borderline diabetes. So that's an additional at-risk group. Next on our list, disabling conditions. So this is a variety of conditions that can impact quality of life, affecting things like mobility and cognitive abilities. One thing that emerged here was our mortality rates associated with Alzheimer's disease. The red representing the local data, green the state, blue the US. And you can see that locally that rate has increased pretty considerably in recent years. So whereas once we were tracking pretty close to state and national trends, that really started to um, break loose in 2018, and local rates went higher than both state and national data. Other measures of disability we found in our survey of residents, for example, that 30% of adults in the community say that they are limited in some way in some activity because of a physical, mental, or emotional health issue. That's close to what we see nationally, but it's significantly higher in women, certainly in older adults, and also significantly higher in those at those lower income levels. Now, another question that asked from a different angle was we asked people if they are themselves the caregiver to a friend or relative with a long-term health issue. And that's true for about 1 out of 5 residents in the community. 1 out of 5 is currently a caregiver to a friend or family member who has some long-term illness, disability, or health issue. Again, similar to what we see nationally. I really just have one slide to share under the umbrella of infant health and family planning, and it's really on the family planning side. And that is the relatively high rate of teen births in the community. For Umatilla County, there were 26.5 births to girls or young women aged 15 to 19 for every 1,000 in that age group. So that rate is more than twice what we see statewide, and certainly significantly above what we see nationally. A few things that I wanted to share around injury and violence. So looking at some of the death data again, we looked at unintentional injuries across the service area. We found that leading causes were things like motor vehicle crashes and falls, which together account for more than half. Third leading cause is, it's technically called poisoning and noxious substances, but I'll share with you that it does include unintentional drug overdoses, which is a primary driver for this share of the pie in most communities. So those are really the top contributors to unintentional injury deaths or accidental deaths, if you will. The rate for unintentional injury deaths, you can see, has tracked fairly close to what we see statewide and nationally, but we are also following a similar upward trend over the past decade. In terms of violence, in our survey, we found that overall 5% of adults say that they themselves have been the victim of a violent crime in the area in the past 5 years, similar to what we see nationally, but really particularly high in certain parts of our community. For example, women experience a prevalence of violence many times what we saw among men responding to our survey. It was age-related, but in this case, much more concentrated in younger adults than in older adults. And again, that low-income segment bears a much higher burden of violence than we see in those in the mid to high income groups. The next topic area that I wanted to cover is mental health. And if you recall, this was that chief concern among those key informants that we surveyed. But I want to look at some of the data from the population survey and from the secondary data sets. So one of those measures is suicide mortality. So this is death certificate-based information gathered through public health data sets showing the trend of suicide, age-adjusted mortality for suicide over the last roughly decade. And you can see that for much of the 2010s, we were experiencing a fairly sharp increase in mortality with a couple of steps down in the last few reporting cycles. So not clearly yet a trend, but certainly much higher than we see nationally throughout the past 10 years, kind of hovering above and then below the statewide mortality rate. In our survey, we asked people about suicide ideation. We asked them in the past year, have they seriously contemplated suicide? And we know that's a sensitive topic, but 5.8% of our respondents acknowledge that yes, they have seriously considered suicide at some point in the last 12 months. And it was much higher in our respondents who were men or who were in, again, those lower income households up to 200% of the federal poverty level. Also in our survey, we asked about things like anxiety and depression. Here we asked people if they have ever had 2 or more years in their life when they felt sad or depressed on most days, even if they had felt okay sometimes. And so we call that symptoms of chronic depression, those kind of prolonged periods in a person's history. That's true for 40% of adults in the total service area, a little below, but statistically within margins to what we see at the national level. By demographics, we do see it higher again in women, in adults in that middle age group, 40 to 64, and in those in lower income households again. So those were statistically significant outliers in these data. We also looked at some of the existing data that's out there that points to the number of mental health providers in the community. For example, here we found a rate of 440.8 mental health providers for every 100,000 population, which puts the area kind of somewhere between what we see for the state and the U.S., better than the state as a whole, but not as good as the national ratio. And this includes, a variety of providers, including psychiatrists, psychologists, clinical social workers, and various counselors that specialize particularly in mental health care. We collected a variety of data around nutrition, physical activity, and weight, and this emerged as an area of opportunity for the community. For example, in our survey of residents, we asked each respondent to our survey to tell us his or her height and weight, and then from that we calculated a body mass index, or BMI, for each respondent, which puts them in a category of being underweight, healthy weight, overweight, or obese. And so in doing that, we found that really about 3 out of 4 adults in the service area, 75.4%, had a BMI of 25 or more, meaning that they are either overweight or obese. That's close to what we saw in 2021, but significantly above the overweight prevalence for the state of Oregon and for the U.S. as a whole. And if we look at the higher threshold of obesity, which is a BMI of 30 or higher, so this is included in the first chart, but if we look more explicitly at obesity, it's 42.6% of adults who are considered obese. Again, similar to what we saw in 2021 locally, and again, higher than what we see for the state and the nation. If we dig into this obesity prevalence and look at it by demographics, really the statistical findings here are for women and those in the lower income segments. Those two groups are statistically higher than their counterparts in the community. We also asked a number of questions around physical activity. So we asked people, for example, what, if any, activities they engaged in the past 30 days, and what intensity, frequency, and duration of those activities. And from those, we can calculate whether people are meeting CDC guidelines for physical activity recommendations. And what we found was that a relatively low percentage of adults really do meet those physical activity recommendations, only 21.5%, which is somewhat close to what we see statewide, but significantly below what we see nationally, where even nationally it's only 30%. Demographically, some of the biggest at-risk groups here are women, again, 40 to 64-year-olds, again, those in lower income households. Those are least likely to get adequate levels of physical activity. In terms of respiratory disease, really just one slide I wanted to share, and it relates to some of the death data that's out there for mortality associated with lung disease. And here, lung disease includes an umbrella of conditions that includes things like emphysema, chronic bronchitis, asthma. And you can see historically for Umatilla County and for the service area, mortality rates have been well above what we see at the state and national level. Not a clear trend. There may be some declines in process, but still significantly above what we see statewide and nationally. And for that reason, it makes our list of these areas of opportunity. We had a number of factors that we looked at also for substance use. For example, in the mortality statistics, we saw a significantly high mortality associated with cirrhosis and liver disease in comparison to what we see statewide and nationally. Now, not all cirrhosis, not all liver disease is alcohol related, but alcohol is the leading contributor to these conditions. We also found a relatively low percent of adults in the population who have ever sought help for an alcohol or drug-related problem. Well below what we see nationally, and much lower than what we saw in 2021. So we didn't see any other indications that this problem has gone away, but we are seeing fewer people seeking help for alcohol and drug-related issues in the latest assessment. And then the last chart that I wanted to share around tobacco use. So we looked at a couple different factors relating to tobacco use. For example, we found that 16.9% of adults in the community currently smoke cigarettes. A little bit above, but statistically similar to what we see for the state of Oregon, and actually better than what we see for the U.S. overall. Similarly, when we asked about vaping, 10.5% of adults locally currently use e-cigarettes or other vaping products every day or on some days. Again, statistically similar to what we see statewide and better than what we see nationally. But I think for this, particularly for the vaping question, I think it's really telling to look at it a little deeper, to the right, you can see that we've seen almost a threefold increase in the past 3 years in the percentage of adults who are using vaping products either every day or some days. And it really is focused and concentrated among men and among adults under 65. And in fact, we found the highest percentage in the 40 to 64 age range in our survey, which may be surprising to folks. So I think those are important findings to keep in mind as we consider tobacco use in the service area. So those are the key data points that I wanted to share with you today. And I know I've gotten a couple questions come in, so I want to address those, but I want to remind everybody else if there's other things that you are thinking about or have questions about, go ahead and put those in the question box now. And we can talk. I can answer those after I address the other ones. Let me review these questions real quick. Give me 1 second and I will respond. So another question came in about the definition of the service area. And part of this requirement for CHI St. Anthony is that it's an IRS requirement to address their population, their primary service area, which doesn't always line up with county borders, of course. So it was more zip code based. So it was really a service area based on a collection of zip codes rather than on whole counties. So that may be different than jurisdictions for like public health departments and others. So that's why it didn't necessarily include the entirety of Morrow County in this case. I believe we did include the entirety of Umatilla. Another question that came through is, does the primary care physician include physician assistants? PAs are being utilized by community members for the primary care in certain communities. Yes, and that was a good point. That was the caveat that I was trying to get across in that slide that showed the rate of primary care physicians for the population size. That is a big caveat to that, is it does not include PAs. It does not include nurse practitioners who may be delivering primary care in certain communities and in certain settings. So that it is a shortcoming of that particular indicator, but it's the one indicator that we have access to. So I do want to recognize that you are correct. That is true. Do you have the falls based on age? So we did. So I think this is related to the slide that I shared where falls was a leading cause of unintentional injury deaths, or one of the leading causes. So we do have, for example, we do have an age-adjusted death rate based on falls in the 65 plus population, for example. There may be some ability to drill down into ages, but it really depends on what the overall count is, because it's in a lot of those secondary data sets, they suppress data once the counts become too small. So it's kind of a may or may not be able to look at that deeper by age. Can you share more about the demographics of those who took the survey and what the limitations might be for that? So I'm going to go back to that slide that I shared at the beginning. So at the bottom right, the red bars represent our final sample, which is a weighted sample, the final sample of the demographics in the survey. You know, the phone surveys were randomly administered throughout the service area. So that really makes a big difference in getting good demographic representation, is that random selection. really limitations for the survey are relatively small. I mean, we didn't survey institutionalized individuals. We surveyed in both English and Spanish, but if there was another language, that might not be represented in our survey. But in terms of the demographic makeup, I'm quite confident that our sample really is a good mirror of the population. Do you have any information for caregiver depression regarding the type of health needs of those that they care for? We didn't have a lot of follow-up questions for the caregiving. I mean, there was 110 questions in the survey, but we still had to make some decisions about what we could and couldn't include. We did have a follow-up that asked people about caregivers about the condition that the recipient is dealing with. We do have an opportunity, to then look at the caregivers and cross-reference some of their questions to depression. So we could see if it is significantly higher in that caregiving group versus the rest of the community. That might be a good opportunity to explore the data a little more. And CHI St. Anthony will have, access to the survey data, beyond just our reporting to look at some of those types of things. But we have not done that as of yet. But I think that's a really interesting question. Was the survey mailed, emailed, or self-initiated, like through a QR code? It was for the resident survey. It was none of those. It was largely a phone-based survey. So we created a universe of phone numbers for known households in the targeted area and randomly selected and called individuals to take part in that survey. Let me check on one thing else. I just want to make sure I was telling you everything correctly. That's true. That was the mode of surveys for this. The availability of mental health care does not seem to align with anecdotal experience. Can you talk a bit more about the types of providers that were included? Do you have any data regarding ability to get care as opposed to providers in the area? So, yeah, so I guess one thing I didn't mention is, we are going to be issuing a full report that St. Anthony has to go through a couple steps, but it will ultimately be posted publicly. And in that report, we have a lot more data than I was able to share with you today. I didn't think anybody wanted to sit through a 4 or 5 hour presentation. So there is a lot more information that we have, and certainly a lot more in mental health. I really tried to share what really emerged as most important from the assessment, but there were a lot of other things that we looked at in the survey around mental health. And one of those was, we asked people about access, and we found, for example, 7.4% of adults said there was a time in the past 12 months when they needed mental health care, but they were not able to get them, or mental health services, but not able to get them. So 7.4%. It was similar to what we saw nationally. We really didn't see big, significant differences by demographic groups, which is one reason I didn't make it into this presentation. But so we did ask for access from the user side as well. We also found that about 19% are currently getting some type of treatment, and that could be either medication or some type of counseling or therapy. Another question asked if we had any questions around social isolation. I don't believe we included any questions around isolation in the current survey. I know there are questions that we have used in the past, but I don't think they made the survey this time around. Again, you'd be surprised how selective you have to be even with 110 questions. Any other questions? I think I've answered all of those that came through in the question dialog box, and I really thank you for submitting those. Sometimes we don't get that much uh, engagement in this piece, so that's kind of a refreshing experience. So thank you for that. So I want to take you then. Let me get back to where I was. I want to spend the last few minutes of this event, and I'm going to let you out early, just spoiler alert, getting your feedback around prioritization. So thinking about, what you heard today, we want to get your input around what's the biggest issues and what you think we can do about it. And so I'm going to have you use that Menti system here in a minute. And I'm going to ask you to look at each of those health issues that I walked through: access, diabetes, cancer, etc. And for each of those, you're going to assign 2 scores. One is what we call scope and severity, and it's basically how big is this problem. I want you to think about what you saw today, what you know about the community, and think about how many people are affected. How did we compare to some of that state or national benchmarking? But also think about the severity of that health issue. To what degree does it lead to death or disability or impact quality of life? Or is it something that exacerbates other health issues? So all of those kind of go into this calculus of how big is the problem. The second score that I'm going to ask you to give is what we call ability to impact. It's essentially asking, is this an area where we can make a difference? What's the likelihood that we could have a positive impact if we were to address this health issue? And I want you to think about collaborative efforts in the community. Certainly, the hospital is asking, what it can do as a key role, but also working in conjunction with other organizations in the community. Now, for this one, I don't want you to get hung up on, resources, and I want more of an instinctual gut reaction here. What we're essentially trying to identify is, which of these are the lower hanging fruit versus what are things that are, maybe generational to change, or that we have, very little ability to impact. So in a moment on your Menti, if you pull it up on your mobile device, it's going to look something like this. You're going to see the health issue at the top, access to healthcare, 2 scores and 2 sliders: scope and severity, ability to impact. The scale for each will be from 1 to 10. For scope and severity, 10 is you think something that is extremely prevalent with very serious consequences. 1, not very prevalent in this community, doesn't have a whole lot of health consequences. Ability to impact, similarly 1 to 10. 10, you think we have a great opportunity to make a difference. 1, no matter what we do, we're not going to make a dent. So that's going to be you'll go through then all of those health issues, moving those sliders for each. So again, it should automatically pop up on your screen. If not, you can hit refresh, or you can re-enter going to menti.com or use the code 77282273 once you get there. If you have any issues getting back in, just drop me a line in the chat box. I can walk you through that. Now, as you go through, I know this will take some time, so I'm going to give you a few moments or several moments to do that. Um, I've hidden the scores. I won't reveal those until we've had a majority of folks come in. But again, very important. Once you have moved all your sliders and cast all your votes, be sure to hit that submit button at the bottom, because that's what'll send it to our screen. Again, the site and the code are at the top of this slide. You can see where it says join at menti.com. So you just enter that into your web browser, and that'll take you to a screen and ask you for the code. It's 77282273. And I know it's going to take several minutes to get through these, but again, be sure to hit that submit button when you are done. Apologies, needed to refresh to get a count of folks. All right, it looks like most have weighed in. I'm going to reveal the responses, but if you're still voting, continue to vote. It'll still count even after I get past this slide. So please take your time if you're still in it. But for the group, I wanted to kind of share where these are starting to appear. One second here. There we go. There we go. So what this does is it takes each health issue and plots it on this matrix with scope and severity on the x-axis. So 1 to 10, ability to impact on the y. So essentially those things closest to the upper right-hand corner are those things closer to a perfect 10-10 score, if you will. So we can see there's kind of a grouping here of 3 that are close. Certainly mental health, that comports with what we saw from the key informants earlier. Diabetes and nutrition, physical activity, and weight. Those are probably the highest scores of the group. Substance abuse not far behind, running out the top 4. And then we kind of have this grouping. We have infant health and family planning and injury and violence. And then in the background, a variety of the other health issues that we talked about. So clearly mental health, diabetes, nutrition, physical activity, and weight were top for this group. And then substance abuse as well. Oh, and access is kind of hiding behind there. Sorry. So top 5 would be mental health, diabetes, nutrition, physical activity, and weight, substance use, and access to healthcare services. So your input today is important because this is going to help lead the hospital from this process of assessing to moving in then to identifying, what it can do to start to address some of these health needs. So I thank you very much for your time. I want to bring Emily back, ask her if there's anything else she would like to add to this. But for my part today, I want to thank you for listening. Emily?
Thank you, Bruce. That was super informative. Just a couple things. So next steps for us, we will get a team together here to work on a community health improvement plan to help address some of these needs. And then the full report that Bruce mentioned will be available on our website probably by next week. And our website is sahpendleton.org. So if you have any questions, please feel free to reach out to me. My email is emily.smith519@commonspirit.org. So again, thank you for joining us, and we look forward to working on this further with you all.
Thank you, everybody. Have a good day.